So our next session focuses on the role of health policy in shaping women's reproductive health in Canada. We'll hear how policy decisions from coverage and regulation to access and delivery directly influence women's health across the life course. It is my pleasure to introduce Dr. Laura Schummers, an epidemiologist and health policy researcher and an assistant professor in the Collaboration for Outcomes Research and Evaluation in the Faculty of Pharmaceutical Sciences at the University of British Columbia. Dr. Schummers completed her doctorate in epidemiology at the Harvard School of Public Health and a postdoctoral fellowship with the British Columbia Ministry of Health and UBC's Contraception and Abortion Research Team. Her research uses population-based administrative data to evaluate how policy and practice changes affect reproductive health service use, access, and outcomes. Her presentation, Health Policy and Women's Reproductive Health in Canada, the Power of Policy to Transform Access, draws on recent research examining how universal no-cost contraceptive coverage in British Columbia has already begun to change access, equity, and health outcomes, and what lessons this holds for national pharmacare and public health reform. Please join me in welcoming Dr. Laura Schummers.
All right, thank you so much for the introduction once again, and it has been such a great day here already. I'm just delighted to now move on to my favorite topics of health policy, and in particular, how health policy can influence women's reproductive health, female reproductive health in Canada, with some good news stories and some lessons for the future. Okay, we've been talking a lot about what is and what is not reproductive health. So I'm just going to situate a bit of where I'm coming from, at least for the purposes of this talk and for much of my research program. So what do I mean when I say reproductive health? How do we think about women's health and women's reproductive health while avoiding thinking of women as perpetually, potentially pregnant, which I really love as a framing and is something that's really near and dear to the way that I've approached this work and what I care about here. So first, for those that could become pregnant, so that's going to be people that have a uterus, that are sexually active with men, or that otherwise could somehow have sperm enter their uterus. Family planning services, so contraception and abortion. This is how women become not perpetually, potentially pregnant. These are tools that give women agency over their reproduction to decide if and when to become pregnant, and if they will continue those pregnancies to birth or not. Then beyond family planning, we can think about women's reproductive health to include the full reproductive life course from menarche to menopause and postmenopause and beyond. From a life course perspective, we know that these life stages that are universal mark the beginning and the end of the reproductive life course for women. And these are key markers, and in some cases, key drivers of health. Yes, reproductive health, but even more broadly, health for more than half of the population. While not the focus of my presentation today, and not really the focus of most of our discussion today, of course, pregnancy outcomes are also important, and we shouldn't take those out of the equation when we think about women's health and women's reproductive health. But for the most part, where I'm going to be focused is on family planning. So what about health policy? What does health policy really mean? In general, we could think that health policy is either legislation and regulation that governs the way that our health systems are implemented, the way that health systems, that we achieve access to these services through our health system setup, as well as coverage and financing. This is true for medication, for various health service delivery models. These are the elements that can serve as policy levers that determine who has access and who pays for that access and what is prioritized. So now I'm going to zoom into family planning. So again, family planning services that I really focus on are contraception and abortion in my research. Increasingly, I think we might consider that assisted reproductive technology to support becoming pregnant for people who need that support really should also belong in this camp of family planning. But for the purposes of today, I'm really going to talk mostly about contraception and abortion. Now, why is this important? So the ability to plan, to time, and to space pregnancy and birth is essential for gender and socioeconomic equity. Unplanned pregnancy by which I mean both mistimed pregnancy, where, yeah, maybe the person did want to become pregnant at some point, but not at the time that they did become pregnant, as well as unwanted pregnancy, where someone never wanted to become pregnant or not in that sort of life stage or circumstance. When people experience an unintended pregnancy, there are long-term sequelae for economic and educational attainment for women, as well as their lifetime economic stability. This affects that individual person who is pregnant, their family, their offspring, with intergenerational effects for a long time. 40% of pregnancies, maybe 50, as we heard earlier, are unintended. Most of those unintended pregnancies, about 60%, end not in abortion, as we might expect, but in birth. Unintended pregnancies are more often exposed to maternal smoking, to alcohol and substance use, and they're less likely to receive adequate and complete antenatal care. Unintended pregnancies, compared with intended pregnancies, have higher risks of low birth weight, of preterm delivery. Offspring are more likely to experience limited or no breastfeeding. There are higher rates even of infant and child abuse in offspring of unintended pregnancies. And then the pregnant individuals are at an increased risk for a number of things as well, including intimate partner violence, which is elevated in pregnancy for everyone, but especially if that pregnancy was unplanned. So when we support populations to plan, to time, and to appropriately space pregnancies, this has substantial impacts on health of populations, yes, women and females, but really beyond that. This is a foundational part of how we achieve population health broadly. So how is Canada doing at delivering these family planning services? And how might policy influence this? So across all of our health systems, I think especially anyone here who works in the clinical space or in health services planning knows that we have strained health systems in general, and we really struggle to provide timely access to a lot of services. But this has historically been especially pronounced for family planning services, to the point that in 2016, the UN's Convention on the Elimination of Discrimination Against Women really chastised the Canadian government for doing a bad job of providing contraception and abortion services. They noted in particular that there was really limited access to abortion care. Fewer than 1 in 6 hospitals offered abortion services, and at that time, abortion care was primarily located in hospital settings. They noted that contraception was unaffordable and that there were real disparities in access for both of these services for those living in rural and remote settings. But the past 7 or 8 years has been a time of rapid policy change in the reproductive health space. So starting with the introduction of mifepristone, the medication abortion pill, in 2017, we talked about that a little bit earlier in the panel, and as much as I love talking about this topic, it's not the focus of today, but I just had to bring it up to at least pique some interest if anyone's not aware of this big change. But then starting in April of 2023, we saw some really rapid-fire changes for drug coverage policy, specifically focused in the reproductive health space. So starting in April of 2023, British Columbia introduced Canada's first universal first-payer coverage for most forms of prescription contraception. Then, shortly thereafter, the federal government passed Bill C-64, which is a legislative framework for federal pharmacare that would provide universal access, single-payer access for all medications. It's a framework for this, starting with contraception and diabetes medicine. I'm sure this is not news to most of us in the room. In the same month, October 2024, Manitoba introduced their universal contraception coverage policy. That was followed by PEI in May of 2025 through the federal pharmacare negotiated agreement, and this is forthcoming in the Yukon. Then in 2025, we saw a new cycle of coverage announcements in the reproductive health space for menopausal hormone therapy. And this time, it was Manitoba that led the way with universal coverage starting just this past July, in July of 2025. And now BC will follow Manitoba's lead and implement the same universal coverage approach starting in March of 2026. So this is a pretty exciting time. So now let's look at what happened when BC made contraception universally free. How did this influence contraception use and method choice? And does this provide a solid case for universal contraception coverage in general? So with actually quite a few folks in this room, we have a 4-year project grant to study this. What happened when BC made contraception free? And we were so keen to just hit the ground running and get these analyses out the door as fast as we could, because we were funded to start this research right when federal pharmacare was rolled out. So our feeling was, everyone's listening, policymakers are ready to jump, let's get moving on this. And so we've been doing exactly that, and I'm excited to share just what our next, oh, come on here, there we go. We published 1 paper on this so far, and we have a few others in the works. So published just this last July in the British Medical Journal, again, with several people whose names you'll recognize that are in the room here. We got our first analysis out. So this uses the kinds of methods that a lot of us epidemiologists and health services and policy researchers tend to use, where we use linked health administrative data to study use within a given population. In our case, this was British Columbia. And doing that, we studied the percent of females between the ages of 15 to 49 that were using any form of prescription contraception. And then we also used a national prescription database to just look at the monthly volume of contraception prescriptions across the country, and if this differed by province. We used, again, a pretty standard approach analytically to really identify the causal effect of a policy change. This is called a quasi-experimental interrupted time series design, which I won't bore you with the details of. So important to know, when we study contraception, we categorize these methods according to their effectiveness. The most effective methods are what we'll call long-acting reversible contraception, or LARC, and you'll see that term on some of my slides to follow. These are generally intrauterine contraceptive devices, or IUDs, as well as the more newly introduced in Canada subdermal contraceptive implant. And these devices are very effective with less than 1% of users becoming pregnant during each year of use, and can remain in place for at least 3 years, and in some cases up to 10 or 12 years. These are as effective at preventing pregnancy as tubal ligation. We could then compare these with what we call tier 2 methods, and these are really the prescription hormonal methods, such as the oral contraceptive pill, the patch, ring, and injectable contraception. And we know that about 4 to 7% of users of these tier 2 methods will become pregnant during each year of typical use. Finally, looking at tier 3 on the bottom, these are non-prescription methods. So these are barrier methods such as condoms or diaphragms, as well as fertility awareness-based methods where people sort of time their sexual activity based on when they're ovulating or at greatest risk of pregnancy. Users of these methods, we see pregnancies roughly about 12 to 24% can become pregnant in each year of use. Okay, so what did we find? I couldn't get away with no data. I mean, this is not an all data talk, but I couldn't leave it out altogether. So here what we're looking at is a slide that shows monthly dispensation volumes for prescription contraception, looking just at those long-acting methods, so IUDs and implants. BC is shown in blue, and then our control group of all provinces that did not make contraception free during our time period are shown in yellow. So what we want to do under this design is estimate what we expect would have happened. So the expected number of LARC prescriptions after the policy change based on the pre-policy trend. So that's what this dotted blue line is that you see here with the red arrow now. And then we compare that to what actually did happen, the observed blue line at the top. And then we can look at the difference between these to estimate the effect of the policy. So in BC, we found that there were about 3,200 LARCs dispensed in each month, starting in April of 2022. And we see a bit of a decline in the pre-policy period in terms of prescription volumes. When BC's policy was introduced, there was then an immediate increase by 1,050 additional LARCs per month than expected. And then by 15 months after the policy took effect, we saw an additional 1,275 LARCs dispensed per month. So this is a huge policy effect. This is an increase by 49% by 15 months post-policy, amounting to an additional 30,000 LARCs dispensed in the population during that time period. And that we can directly attribute to this policy rollout. Now we're looking at something a little less exciting, which is what happened to monthly prescription volumes for all methods of prescription contraception, so not just those long-acting methods, but adding in the pill, patch, ring, and injectables. And the scale here is really different. There were 58,000 prescriptions dispensed in April of 2021, and this was, again, declining kind of quickly here. Then we saw that when the policy was introduced, there was an increase by 4,000 dispensations right at the outset, and the declining trend slowed down a little bit, but by June of 2024, we found an additional 1,980 prescriptions dispensed per month, which was significant but pretty small marginally compared to the baseline there. One question, certainly in BC, is whether the increased uptake and use of long-acting reversible contraception would bear out also for rural populations, because this is something that requires someone with expertise in placing one of these devices, and it's uncertain what the geographical distribution of those providers will be. So we've so far just scratched the surface of this analysis, where we just looked at dispensation volumes among rural compared with urban groups, and of course the numbers are much smaller in the rural group. These are smaller populations, but we did find that the magnitude of increase was similar, which provides an encouraging first look at what accessibility might be looking like in rural zones. Whoops. Okay. And then also exciting, we have some early analyses for Manitoba, and so that's pretty fresh. We only have 6 months of post-policy data, but we can see here that, again, the magnitude of increase was really similar. So by 6 months post-policy for Manitoba, the increase in LARC dispensations was about a 33% increase. So in that same neighborhood, and I think that's really encouraging for other jurisdictions who may, or Alberta may not be considering implementing such a policy change, but I think we can see that there's some generalizability of what we're finding in BC. This is not a BC-only phenomenon. This looks like it would be true in other places too. Again, looking in Manitoba at all prescription methods, this is kind of washed out, and we don't see much of a change even after this policy change, looking at monthly dispensation volumes. Okay, now I'm going to switch over to our population-based health administrative data, where we're not measuring the kind of crude counts of prescriptions out the door at a pharmacy, but we're instead looking per month what percentage of females between the ages of 15 to 49 have an active episode of contraception use of some sort. Now, I don't expect this number to ever reach 100%. We know not all people are ever at risk of pregnancy, do not need contraception, are not sexually active, are not heterosexual, don't have a uterus, but I don't know all of who is who in these data. So we're starting here by looking at what percentage of this group are using contraception. Now, looking at LARC, we can see that 22% of the population were using LARC in April of 2021 at the start of our, sorry, this is not LARC, all prescription contraception. We're using all prescription contraception in April of 2021. And again, check out that decline. That dropped down to just below 20% before the policy was introduced. And then we saw that the introduction of BC's policy led to a flattening of the declining curve, but not a full reversal. So again, because we're comparing the expected numbers to the observed numbers, we still measure that as an increase, where there was an additional 1.7% of reproductive aged females using any form of prescription contraception by June of 2024 than we expected there would have been without the policy change. That amounts to about 14,000 additional contraception users in a cohort of about 900,000 people. Now looking at long-acting reversible contraception only, we see that 9% of our population were using these methods at the start of our study period, and we then again expected to see this start to decline after a peak use in April of 2021. And when we compare with the expected value, we can see that there were an additional 11,400 users of long-acting methods than expected, which is an increase by 1.3% of the population. So again, that's a pretty big increase. Doesn't look quite as dramatic as the prescription dispensations. All right, now let's talk a little bit about money. So we were talking about the fact that one of the policy levers to influence reproductive health access or health access in general is about financing. So here what we're looking at is the percentage of contraception dispensed according to out-of-pocket payer. So this is where at the pharmacy level, a private plan did not cover this prescription, nor did a public plan. And instead, this was a patient paying out of pocket at the pharmacy till for their medication. BC is bolded here in black. And pretty staggeringly, before the policy change, 39% of dispensed contraception was paid out of pocket by patients. This doesn't really make a lot of sense when we hear things about, from some of these drug coverage reports saying almost everyone has coverage for medications. We just need a couple more Band-Aids to fill in those cracks. But really, that is not borne out by what we found for contraception. This is nearly half of dispensed contraception being paid out of pocket. And why might this be? Well, contraception is a little bit unique for a few reasons. The population that uses contraception is disproportionately young and healthy. So they don't have as many ongoing dispensations for medications that would hit those annual deductibles when some of these other coverage plans might kick in. That's one thing. We know that young females are the least likely group in the population to have private drug coverage in general, or to have private sort of supplemental health insurance across Canada. We also know that privacy and confidentiality for contraception is uniquely important. So if a household has private insurance for drugs and a dispensation goes out, who is alerted? The plan holder. And that is going to be the sort of economic head of household in a lot of contexts, which certainly for youth or young adults, that's likely to be a parent. In some cases, that might be the spouse of someone who doesn't share the same family planning goals. This might be someone experiencing reproductive coercion, or someone for whom a pregnancy in that environment would not be safe, nor would discussing their need or desire to use contraception. I can't measure how often each of these different factors are happening, but I can see that this 40% is telling a story that we need to listen to. Finally, some of the private plans actually don't cover contraception because it is that's not treating a disease in many cases when the use is for preventing pregnancy. Okay. That's the background here. So then when the policy was introduced, what happened? Well, this immediately dropped to 12% of dispensed contraception, and then that dropped a little further down to 9% when BC expanded the formulary of which kinds of contraceptives they would cover. Then we see Manitoba come into the fold again, and for them, before their policy was introduced, 32% of contraception dispensed was paid out of pocket, and this came right down to the same 9% that BC found. And then if we look at the other provinces, Alberta is shown there in orange, so I put that little 30% arrow, telling us that in Alberta, it has been 30% of contraception paid out of pocket, and that is still true. That has not changed. Then let's see what happens when we look at the public payer. Not so surprisingly, we see a big jump where we went in BC from 12% of contraception dispensed paid by the public insurance plan up to over 80%, to 82%. We see something very similar in Manitoba, and then we can see what that sort of baseline rate looks like in the other provinces, ranging from 8 to 18% of contraception that's covered. Now, if anyone is in like the health financing world, that might sound alarming. How are we going to pay for this? But let's just recall that for contraception, what we expect, we have pretty solid evidence from other jurisdictions that have done this. For every dollar that is paid for contraception in a single-payer health system, they will save at least $5 and more likely up to $9 in health system spending across the board. This is through averting unintended pregnancy, and this is also through preventing other gynecological procedures that are not always necessary if someone has easy access to especially an IUD and sometimes other methods of contraception. So this figure here is from the cost effectiveness study that was led by my colleague Wendy Norman over here in the corner, but that really gave rise to this policy change in BC. And what this is looking at is, what do all these lines mean here? We're really focusing on the dark blue lines. And they're showing us the dark blue here in this first year is telling us that the public payer is going to be footing the bill of about $35 million in that first year to pay for all those new IUDs. Then in the second year, there will be another roughly $25 million paid, and by the third quarter of the second year, they'll reach cost neutrality, where the amount that was paid for contraception equals the amount that was saved by not having those unintended pregnancies and unneeded gynecological procedures. Then more so, looking by year 4, we expect to see $25 million saved annually by the health system by this investment in women's health by making contraception free. So yes, the public purse is out at first, but this is an investment, not a cost. Okay, so overall, what did we find so far? Use has increased a lot. And importantly, virtually all of the increase in use was for those most effective long-acting reversible methods. So this tells us that in a Canadian context, a policy that eliminates cost sharing for all methods led individuals to preferentially select the most effective contraception methods because cost was a barrier to use overall, and cost was driving people to use less effective or no contraception. That should be a wake-up call. We also found that the policy led to a huge drop in out-of-pocket costs. Yes, that's a no-brainer. Of course, we all expected it's going to lead to a drop, but that magnitude of change, again, should be an eye-opener. That is surprising. So in my opinion, yes, these findings do make a strong case for universal contraception, and we're only in year one of this project where we're going to be looking at those other things, like what happens to abortion rates, what happens to health system costs writ large. But so far, I've been really just telling a good news story, and unfortunately, this is not only a good news story. All of that enthusiasm we had at the beginning to say, finally, we have federal pharmacare in place, and BC is going to be able to give this evidence. When Federal Minister Holland announced federal pharmacare, he said, we'll be looking to BC as the blueprint for what this is going to look like. We've heard something similar from the current Health Minister, Marjorie, saying, let's look and see what the jurisdictions let's wait and see what the evidence has to say. We have evidence here, and yet right now we have 4 jurisdictions with federal pharmacare agreements in place, and that is just not enough. It's not clear what we're waiting for. We made this case in a recent article in The Conversation, trying to just say, like, draw attention to this and say, this is the time, we have the evidence, there's nothing else we're waiting for other than political will. What's more, the more time that elapses here, we're letting this conversation reopen to say, if federal pharmacare is introduced, should it really be single payer? Do we really need that? Or maybe we should just add a few more Band-Aids, because isn't that really what we need? And that is not the case. This is being led by lobbyists really focusing on keeping private insurers in the loop in this discussion. And that is just simply not who should be driving health policy decisions in a single payer system like we have here in Canada. This is a problem in Canada, especially for reproductive health and reproductive health equity. Okay, so the second reason that this is not only a good news story. So we've really glossed over the pre-policy context here at the beginning. I think I've explained that we were so excited to get out the door that we wanted to just see, like, what is the policy effect? And we've done that for the first part of our outcomes, and that's great. But as I mentioned, we saw this declining trend in contraception use in the pre-policy period. This is noise. We modeled it away, thankfully, for our policy evaluation. But really, this is not noise. These trends are telling us another story. So this is now looking in our cohort of reproductive age females in BC between ages of 15 to 49. And in green at first, what we can see is users of all forms of prescription contraception. The cohort setup is a little bit different here. So the numbers vary a little bit from what I showed before because we're no longer working in direct partnership with the Ministry of Health like we have been. So what we see is that in 2018, 16% of reproductive age females were using any method of contraception. And this then increased to just about 20% in April of 2021, after which it started to precipitously decline. When we then look by contraceptive method type, we see that short-acting contraception, shown in purple, is really where the decline was found, where long-acting reversible contraception use is increasing. That is good news, of course, to see long-acting reversible contraception increasing, but what's going on with short-acting methods? Oops, sorry, I had those in there, I forgot about that. All right, now let's take a look by age. When we do this, this whole situation comes into focus just a bit more. So looking at the top in red, we're seeing those age 20 to 29. So these are the most frequent users of contraception, a very fertile group that they're not living with their parents anymore, perhaps for the most part, and in a highly fertile year, sometimes with precarious employment that may or may not have prescription drug coverage. So here we see that use was fairly stable from 2018 to 2020, and then it increased to a maximum of 26% of users in 2021, and then just started to fall off a cliff. This came down to under 20% of females in this group by the end of, right before the policy took effect. And then we just basically see like a blip in this decline that is that huge policy effect that we were just so excited about. So yes, that policy effect made a difference, but that is dwarfed in this age group by the declining use that we're seeing more broadly. The decline slowed down after the policy change, but is still declining. Then when we look at the youngest age group, so these are females age 15 to 19, we see a very similar pattern, just lower use overall. So about 15% of females in this age group were using contraception in 2018. This then peaked up to about 18.5% in 2021, and then dropped down to 14%. The flip side is when we look at those age 30 to 39, they're kind of hiding in here a little bit. The green group is kind of hiding in the average. They're fairly stable, not a huge change to report there. And then the oldest age group, age 40 to 49, we just see a slow and steady increase, which is good for lots of reasons, but not the target group for preventing unintended pregnancy. Okay, so now we're just looking at this across the board, and what we really see here is that the decline in use is just driven by those younger age groups, whereas things are stable or increasing for the older age groups. All right, so now we wanted to model these changes to understand these two things together. So without the policy, what did we think would have happened, and then how did the policy influence this for each of these age groups separately? So in the youngest age group, we can see that use really dropped from 18% in 2021 to 15% before the policy, and that we expected that would have continued down to 12% by the end of 2024 without a policy intervention. With the policy intervention, we do see a change. So this amounted to an additional 2.3% of this population using contraception than expected, but still a real drop from that 2021 period. Similarly, looking at those aged 20 to 29, again, from a 26% peak in 2021, this dropped down to just 21% right before the policy change. We expected it to go all the way down to 17%, but we saw an additional 2.8% of females in this age group started to use, or were using contraception attributable to the change in policy. Again, nothing so exciting here, a small decline and just a small increase where 0.7% of those aged 30 to 39 were using contraception than expected. And something really similar in the older age group. We saw a slow increase, which was expected to continue increasing and then increased a little bit more quickly with the policy. So altogether, we do see a policy effect that is meaningful and important in all of the age groups, but that's not the whole story. What is going on with these stark differences by age, and why is there such a steep decline in those younger age groups? So this is not the first time this term has come up. When our paper was published in July this year, there was a lot of media attention. It was like a whole buzz and excitement about like, wow, more LARC are being used, this is great news, and it is great news, and I'm not gonna ever say it's not good news. But I had this great discussion with one of the reporters of the Globe and Mail about like, is this paper evidence of a decline in use? And I wasn't really ready to say that yet because we didn't have the analysis set up to really answer that question. But now we do. I mean, we are seeing evidence of a decline in use. And why would she have asked that? Well, in the past couple of years, and especially in the last year, the role of online influencers in guiding contraception choices has really come to center focus. Just argued in this September piece from The Guardian, this is just from last month, younger generations are being inundated with messages that birth control is poison, false claims that taking hormonal contraception will cause infertility, will change your romantic decisions and make you attracted to a man that you otherwise wouldn't have been attracted to, as well as a real overemphasis of, yeah, indeed, it's there. And there was a low-level, not great paper that led to that seed. So sometimes this misinformation has a seed in bad science, and this is one such example. Other online influencers really emphasize known side effects through stories about weight gain and depression, or showing the like taking a photo of themselves for every day for a month, and like this is me on birth control and off birth control, and there's a lot there. There is a lot of online information. So academics are studying this, not me, but others. So this paper was also out in July of 2025, where researchers analyzed 100 TikTok videos with the top 5 contraception-related hashtags. Altogether, these 100 TikTok videos received nearly 5 billion views. And they analyzed the content of these videos to see, is it accurate, and is there sort of any systematic preference for one method or one message over another? And what they found was that this was poor information. It was not valid. It didn't have any scientific or evidence basis whatsoever. And it really favored natural contraceptive methods. So these fertility awareness-based methods that I talked about before, again, where we expect pregnancy in 12 to 24% of users per year of use, we're really saying cycle tracking is a better way over something like prescription or hormonal options to preserve your health and wellness. They were really sowing distrust in health professionals, saying that is not where you should get your health information. Come to my wellness website, and that's where you should get your reproductive health information. Related to the panel we just heard before, only a small handful of these were actually created by medical professionals. So there's maybe a bit of a gap here in terms of who needs to be getting this information out there in a way that's digestible. And then, I mean, this is like one example that I liked, but I mean, there are a whole bunch of these that are popping up all over. You know, check PubMed for this, and this is now a pretty vibrant area of research. And what do patients and the public say they're finding about contraception in these social media information sources? So again, this qualitative study, not my area, but important here to understand the why that I can't tell you with those trends, looking at what European adolescent and young adults are saying about oral contraceptive pill information they're getting from social media. So this first quote mentions that social media talk about contraception, side effects, and stories of people going off the pill, how this is really motivating them to learn more about the side effects and why they might consider going off of the pill even if they weren't really considering it previously. This participant describes their experience of reduced libido while on the pill and that this improved after going off the pill. We see others mentioning concerns with their provider, like contraception prescribing is motivated by financial gain, or that prescribing may not be in the best interest of the patient, and that for some reason their physician is prescribing them contraception for some other reason. I think some of these are telling us patients aren't always feeling listened to when they're trying to talk about their concerns. When they come in and say, like, I'm thinking about natural family planning, what do you think? They're not always feeling heard. All right, so Canada's Society of Obstetricians and Gynecologists has been raising alarm bells about this issue. In July of 2024, they issued a position statement about one of the fertility awareness-based contraceptive apps, so a period tracker, which received Health Canada approval in 2024 as a contraceptive. The society called attention to this, saying that this is really not appropriate and is not something that they would consider a valid contraceptive method, and really they weren't consulted in this process. Then again, in October of 2024, the Society issued yet another statement about the growing threat of misinformation related to women's health issues specifically, really noting that social media and gaming and algorithm-driven platforms can lead to harm for women. This is, again, not just about, sort of wasting your time doing something you shouldn't do, looking at TikTok, but you will make a health decision that can negatively impact your health, your education, your social and socioeconomic attainment for years to come. And then I think that this was mentioned earlier, I think by Erin, that last week, not so long after the Trump acetaminophen declaration, the Society of Obstetricians and Gynecologists took this a step further, calling misinformation a form of violence against women. This really emphasizes the fact that there's a real systemic focus of these mis- and disinformation campaigns on women's reproductive health. This is not a coincidence. We didn't just happen to stumble into this for contraception. There's really a systematic focus on these areas within the mis- and disinformation campaigns, alongside other sort of hot-button issues like vaccines. Perhaps reassuringly, most adolescents and young adults still want to get their health information from healthcare providers. So this is looking at a paper published in JAMA Open from a US survey comparing by age group their preferred information source about contraception versus their actual information source. So we see the preferred methods in dark blue and then the actual shown in yellow. So what they found here is that over 60% of teens and 80% of young adults want to get their contraception information from clinicians, but less than half do. They also noted that their parents are the next preferred source of information, but most are not able to get their contraception information from their parents. In contrast, 20 to 30% reported getting their contraception information from social media, even though fewer than 10% see that as a preferred source. And maybe most alarmingly, very few, of course, would prefer to have no information source about contraception, but over 30% report having no information source for contraception. So misinformation about contraception is concerning. And I don't have a direct link in Canada to say whether people who discontinued use or who would have initiated contraception and did not initiate contraception, if that was because of their influence from this misinformation campaign or not. And I do need to consider, are there other alternative explanations that could be why we see this decline in use. And one possibility is like, is there a decrease in need for contraception? I think we're hearing from surveys elsewhere, we don't have this in Canada, that sometimes some youth are having less sex and starting sex later. So this is looking here at a survey, a longitudinal survey that includes information about sexual activity stratified by age group in California. This was published recently also, within the last few months. And what they found was that the percent of Californians aged 18 to 30 that had no sexual partner over the past year had increased pretty substantially to almost 40% of their survey respondents. So that's a possibility here, but I think there's no chance that that fully explains what we're seeing for contraception. So what can we do about this? So we have a room here of smart, thoughtful policymakers, researchers, community members, community-engaged organizational leaders, clinical providers. What's the homework that we can do to work on this? So I think all of us need to think about what we can do to counter misinformation and to disseminate digestible and evidence-informed information that can be that trusted source that youth and young adults want. Policy-wise, we need federal pharmacare. We see a huge policy effect. And given that we are seeing a real drop in use, we need to combat that by removing systemic barriers to contraception use within our health system. And we've found in BC, as well as in Manitoba, that making contraception free is one very effective way to do that. Clinically, I think what we need to do is listen to patients. And if patients are coming in where their first source of information was TikTok, we can't dismiss the idea that fertility-based awareness and fertility tracking is what they want to do. And only by gaining their trust is there any possibility of thinking about maybe, are the teen years the right time for fertility-based awareness methods? Are you really in tune with your menstrual cycle or not? Those are the kinds of conversations that could lead to that person making a different choice, not being coerced, but deciding that that's not actually best for them right now because a pregnancy would really derail things. And then for research, we need to be ready to continue hitting the ground running. We're gonna be playing catch up here because if we start to see that teen pregnancy rates are increasing and abortion rates are increasing, I mentioned the Scotland example earlier in the panel, and Scotland is finding huge increases in abortion rates. So we need to be ready to try to sound alarm bells if we start to see those lagging indicators of poor contraception access. And we need to all talk to each other while we're doing each of these different assignments. Okay, that's the end of the family planning part. So just for a moment here, I'm gonna scale back and think about this, this broader context about women's health and the menarche to menopause cycle. And is there a role for health policy and what does that look like? I don't have a long list of my own studies here, although I do have a study planned to do some of this. But I have a bit of a call to action. So right from the start of menarche, there's really nothing about that we do not look carefully enough at the really rich source of information that the menstrual cycle can offer. This is true about age at menarche, age at menopause, and the characteristics of someone's menstrual cycle, their menstrual health. This is something published in the Lancet's new Obstetrics, Gynecology, and Women's Health journal, just out in their sort of first maiden voyage issue in September of this year, where the researchers are arguing that menstrual health really could be another vital sign for women's health, where depending on what someone's menstrual health looks like, that actually tells us whether they're at increased risk of cardiovascular disease, what their bone health might look like, even diabetes risk, and all-cause mortality. This is something we certainly don't measure and collect in administrative data, and sometimes we don't even really talk about it clinically. Unless there's a real problem, it's just a non-issue that isn't really talked about. This came up a bit earlier with, in terms of policy, where menstrual period poverty and menstrual equity is something that we did see a real win in 2023 when the federal government mandated regulated workplaces to provide free access to menstrual products. This also happened through the Menstrual Equity Fund. And these are important steps, again, to put the spotlight on this cost-related inequity that women and people with uteruses who menstruate across the gender spectrum have been disproportionately needing to just pay for. You're the person who can have a baby, okay, well then you're gonna pay for all of your period products, you're gonna pay for your contraception, and then what's next? You're gonna pay for your menopausal hormone therapy if you're lucky to get it. So continuing around here, around this cycle here, We're now looking at those 2025 policies that are starting to make menopausal hormone therapy available for free, starting again in Manitoba and then with BC. And I hope this is really a growing awareness of the added cost that women face just by existing as females, and that really this is a starting point, scratching the surface for where policy can lead to economic equity. And as we may hear in this next session, menopause is really having a moment. Like, this is looking in the last week alone that we're in a time where there's just a groundswell of attention to the dire need for better care to manage symptoms of menopause. So we can see a new medication was just approved in the US, I'm not saying it's available here. We're seeing all kinds of things about, impacts of menopause on marital wellness. We're seeing things about increased screening. This is in the UK, which just sounds like a really great initiative of having menopause screening integrated into a primary care service. We're also seeing all kinds of things about just personal stories, where celebrities and influencers are telling their tales, their menopausal woes. And really, it's about time for this. And now, in my last stop on this reproductive health journey for today, looking at pregnancy outcomes, this is an area where actually I started my research looking at birth outcomes specifically, and then as we talked about a little bit earlier in the day, really expanding this to include not only birth outcomes, but the other 40% of pregnancies. And this is something that throughout the day today, I think we've done a great job of talking about what is not being researched. Like what we have these things that are getting a lot of focus, what is not getting a lot of focus. And these early pregnancy outcomes are an area that are also part of pregnancy outcomes. So miscarriage is a pregnancy outcome, abortion is a pregnancy outcome, and we need more research and more clinical care to make sure that people are well cared for during that time, even if their pregnancy does not result in a baby. So bringing this all together, what I see here today is an agenda of under-researched domains within women's health, especially those with lagging policy and health service delivery for a real range of women's reproductive health from menarche through menopause. We know that even where we can see success for policy levers that have improved access, these are not being uniformly leveraged across the country, and this is leaving many women in many parts of Canada behind. I think we know the discussion about innovation and bench science that, we're just scratching the surface about what the new areas are for discovery and innovation as well as policy improvement to close this gap. Something that some of us may have seen is this McKinsey Institute. They published a report last week concluding that women in Canada spend 24% more time than men in poor health, and that closing this gender gap would have, of course, improve health outcomes for the millions of women in Canada, but also would boost the Canadian economy by at least $37 billion annually by the year 2040. So I think let's listen to our experts. How do we close this gap? Yes, for women's health and their outcomes, including reproduction and beyond, but even for socioeconomic success and social success of our country. Let's see the agenda that we're outlined today as a starting point. Thank you. I'm just going to say thanks.
Yeah, let's sit. I need my tablet here. Thank you so much, Laura. An amazing talk and a call to action for everyone. So I was checking as you were speaking about questions that were popping up in the Slido, and I know there are many, but maybe as I'm loading that, you can speak to what advocacy happened in British Columbia and Manitoba that allowed such early adoption of the free contraception coverage under the pharmacare plan, and perhaps for the people in this room, how could we model that here?
Yeah, so I'll first say I don't think it was early, although it was first. It was actually very late, and this took over 10 years of advocacy. This was really led by a mentor and colleague of mine who is in this room. Sorry, Wendy, to put you on the spotlight there, but Wendy can raise her hand. She really led this charge. There we go. And this was not an overnight process. This was a direct, close partnership over at least a decade of talking through how smart a policy this is. To say that you will save money by investing in women, and this will be popular. This is like a win-win-win type of policy. And despite that, it took 10 years from an initial policymaker discussion to implementation. And why was it successful is because we have a really great connection between policymakers, health system leaders, and researchers in BC around these early pregnancy and family planning issues that made the government ready to listen. And so we had, two officers of public health officers of BC that were really ready to listen to this and ready to make a difference and push for this to the extent that they could. And then that just happened at the same time with an NDP government, and that paved the way for making this happen. But the partnerships and relationships with policymakers so that a researcher is a trusted source of information, I think is really the key to that success.
Thank you. So as practitioners, many of the people in this room have one encounter with a patient, and we've heard from you that they're getting a lot of their information on social media, from friends, probably from not the sources they wish. And so how can practitioners have conversations, respectful conversations about approaching contraception and family planning when the province doesn't financially support contraception like they do in BC? Like what way can physicians and other clinicians, what way can they approach these conversations?
Yeah, that's a really great question. And I think even in a context where contraception is free, those can be difficult conversations that are sensitive. So when cost, I think understanding someone's payment situation. So do you have private coverage? Would this be something you're comfortable sharing with your household members is a reasonable starting place. And as well as being connected to community organizations that provide access to contraception outside the sort of typical retail pharmacy environment is one possibility. In BC, that's things like sexual and reproductive health clinics. Alberta has some of those as well, or public health clinics. So having those links and relationships and knowing about those and where to tell patients they might be able to go if using private insurance or if they don't have private insurance is not an option.
Yeah, maybe you could speak to, and this is more of like a question about the data, which you're an epidemiologist, so you'll appreciate that. That data that you used up there, using the admin data that you worked with the ministry to get, like how do you account for, or can you account for, or assume it's stable, the amount of contraception use that might be used for purposes other than contraception?
Yeah, it's a great question. It's something that we are hoping to look at in the next while. Is just, we don't have indication for any medication use in administrative data. So we can look at things like, a new diagnosis of something like PCOS and then an oral contraceptive pill dispensation. And we can see if there's sort of systematic differences between people who might have those diagnoses and then have a new initiation of a hormonal contraceptive method. But we won't be able to know for sure if that's true. Looking to other data sets, we saw a survey recently published in Europe with up to 50% of contraception dispensed was for purposes other than pregnancy prevention. So this is not a small fraction of people, and we can look for kind of systematic changes and differences between those groups, but that's something we can't do perfectly, and we would do much better by using good surveys that ask this kind of question in a survey environment or even like a small cohort study.
Fantastic, thank you. Maybe there's people in the audience who want to take that on.
Yeah, exactly.
So thinking about the implications of free contraception, there's lots of questions here about, what about a potential reduction in cancers? What about what's going to happen in 5 years when all these LARCs need to be replaced? Like, what are the next things that you're going to be looking at with your data? Like you got that initial analysis done. Congratulations on that paper in the Lancet. Like what other things are you going to be looking for in the long term following this policy change?
Yeah, so we're going to be looking at changes in the abortion rate. So did this change? And did this change within age strata or other meaningful strata within our population? We'll also look at the health system costs as a whole. For that, we'll do that comprehensively. So what is that net money out the door and net money saved? But at the same time, we'll look at specific ways in which the health system might save money. So looking at things like changes in tubal ligations or hysterectomies and whether that has a direct influence. I think seeing the older age groups and people in their 40s using more and more IUDs, I think we will expect to see fewer tubal ligations and hysterectomies, which will be important for saving the health system money and might be better for a lot of patients. They might prefer that. And so that's a big part. And other than that, we're planning to look into some other provinces as well. So what happened in Manitoba, and sorry to say, but Alberta is our control province for some of those health administrative data. So we're hoping that you'll switch from being a control to being an exposed province with this policy, but for the time being, we have a few years where that policy change did not happen. So having those comparisons will be, I think, especially important given the huge time trends that we're finding.
Yeah, and a popular question here that you might not have the answer to, but I want to hear your thoughts. So you may or may not be familiar that there was a policy change at the government level, changing the provision of sex education in schools from something that happened to something that was opt-in. And so I'm wondering, I mean, I believe the design that you used for your other study could be used in parallel here, but are you aware of any work that's planned, or maybe you could speak to what type of work could be done to explore the effects of that policy change of opt-in sexual education in schools on outcomes?
Yeah, so I did see that policy change happened, and yesterday I spoke with Fiona Clement, who I'm sure most of the people here know about the fact that a study should really be done to look at that. And we were sort of brainstorming about what that study might look like. And it would be great if we could measure like what fraction of students are not opted in, and we were really thinking about how this is likely to really impact marginalized families the most, even if they would have opted in. But this is, did the paper make it out of the bag? Did you sign it? Did it get back into the bag? Did you bring it to the teacher? Like all of those things that, just like a field trip form, the kids who miss out on the field trip are now going to miss out on sex ed, and those are going to be the kids who need it the most. So I think, yes, we can look at whether there's a change in contraception use. It'll probably be hard to look at some of those downstream effects, like what happens to those pregnancies, because that won't be immediate with the policy change. Some qualitative work in BC, led by a colleague now at the University of Washington, has found that adolescents want information from school. So this is a really bad policy. Like school, students are saying, adolescents are saying, I don't know. Like I'm looking at social media, I can't figure out if this is like a good doctor. Someone has a white coat on, but really they're, just like an influencer that doesn't have any training. So I need my source to tell me that it's an official source of information. I need it to have a government logo. I need it to be in school. I need it to show that clear messaging that this is a trusted source and why.
Thank you. So what about, I love this question, like what about contraception from the male or man perspective, like male contraception, vasectomies? Is there any data on trends related to those? Yeah,
so that was something I was hoping to include in our study. Unfortunately, the setup in BC is that the public system for vasectomies is so backlogged that there would be like a 3-year lag before we could see a policy effect, because there is a spillover into private clinics for a lot of vasectomies. And so that's something that should be studied. I wish we could study it. I don't know also, like, what's the best outcome? Like, I don't know that a drop in vasectomies is the end goal. Like, the safest, best option for contraception from a women's health perspective is for their male partner to have a vasectomy. So the goal is not to remove vasectomies from the equation, and I wish I could study that. But in BC, no. Maybe in Manitoba. We'll have to see.
And maybe a few final questions, maybe more on access. What about the declining availability of family physicians and the important role that primary care providers play in both discussing and dispensing pharmaceuticals and long-acting reproductive methods? Like, if young people are less likely to have a family doctor, if there are less family doctors, like what is the impact of that going to play out on this situation? Yeah,
I think that's a really good question, and is something that might be a contributor to that decline in use that we're seeing in those younger age groups, and is a really important one. In BC, 2 months after contraception was free, they also announced pharmacist expanded scope for prescribing contraception. And in many ways, this announcement came as like, here's a solution to the primary care crisis. We're going to let pharmacists do an increasing number of things. And while that is happening, and there are a lot of pharmacists who are now dispensing, I think that's not the solution. Like, that's not the same as having a comprehensive, having a relationship with a trusted family physician and have full suite counseling about the preferred contraceptive method. So I think I'm bringing that up as, yes, that's one way that access can be improved, but no, that's not the solution. That's a stopgap, hopefully. I guess that there's a lot of emphasis being put on BC's new medical school, aiming to suddenly train up a lot more primary care physicians, and we'll see what happens. But yes, this should be a primary care service. And when it moves out of primary care, I think the quality will go down.
Thank you. Thank you so much. Wow, we got through so many questions just then, Laura. Everyone, thank you join me in thanking Laura so much for her insights and valuable work.
Thank you. Thanks for having me.